Welcome to the Myopia podcast, where we give you the latest myopia research, clinical topics, and industry insights. Make sure to subscribe to stay up to date on all awesome myopia content. And now to our host, a massive myopia manager himself, Dr. David Kading.
Thanks again for joining us for this episode of the Myopia podcast. I am excited to be joined by Dr. Baartman. He is a refractive and cataract specialist, and seems a little weird to have somebody who is treating refractive surgery on the Myopia podcast. But there are so many times with my myopia discussions with patients that I bring up things that you deal with every day. And so we're excited to get to talk to you about it. Tell us a little bit about you and your practice.
Yeah, thanks. I'm thrilled to be here. I'm thrilled to be at this conference. This is incredible. I'm now 7 years into practice out of a corneal refractive anterior segment fellowship, where I've kind of shaped my practice around four main things: cornea and corneal disease, things like transplants and keratoconus, refractive surgery, which I'm sure we'll talk a little bit about today, cataract surgery and advanced implants, as well as minimally invasive glaucoma surgery. So my practice is fairly surgical heavy. I spend 4 out of the 5 days of the week in the operating room, and I work with some absolutely fantastic clinicians to help me on the clinical side too. So, you caught me on a day out of the operating room, which feels a little uncomfortable in something other than scrubs, but I'm happy to be here and talking with you.
Yeah, man, I've got so many questions for you. So I want to start with maybe one of the biggest questions that people in the orthokeratology world think of is I'd love to get your take a little bit on orthokeratology. We've heard over the years that there is a disparity between the acceptance and understanding of ortho-K for optometry versus ophthalmology. And just kind of curious if you can share where you think we should or shouldn't be utilizing ortho-K in our practices.
Well, I mean, the bottom line is I think anything that can meaningfully reduce myopia, we're marching towards the same goal, right? And so I am familiar slightly with some of those differing opinions on orthokeratology, but I think the beauty of the practice of ortho-K is really in the data, right? And so anybody who spends time looking at the data, whether it's safety or effectiveness or its impact on future vision correction surgeries, which I've done, knows that it's very safe. It's something that I think can help reduce the amount of vision correction surgery that would one day be needed in those patients that are likely in these scenarios not of the age where they can have vision correction yet, right? And so there are meaningful things that can be done for patients' eyes before they hit the age of refractive surgery. Right. And in my mind, that is the realm in which I don't belong there, and but I love to see the data that's coming out of that.
Yeah, I appreciate that answer because it seems as if when I'm talking to a newer generation of 40, 45, 50, 55-year-old ophthalmologists, they tend to be a little bit more advantageous towards the correction with orthokeratology. And it's as if there was an old school approach, which there's an old school approach on a lot of optometry things where we were wrong on a lot of issues. But you bring up the data, and I appreciate that so much. There's a study, and I actually just had somebody on, we talked about MK, she's a researcher in that, and how there is risks with any contact lens modality, but maybe a little slighter risk of MK with orthokeratology because you're wearing it at night. But on the cross aspect of that, Mark Bullimore has published a paper looking at the risks of progressive disease comparatively to the risks of developing a microbial keratitis event and the loss of an eye from the risk of having myopia. And so the risk in his paper, this was a very statistical paper, the statistical risk of wearing an Ortho-K lens far outweighed the risk of the progressive myopia. And it was just like a brilliant, that kind of brings it under wraps here. So that's kind of interesting.
The other thing that I think is worth mentioning is, there are now studies that you guys talk ever about QALYs, the quality of life years, measurement tools. I wish I had the numbers off the top of my head, but both.
We make up stuff on the podcast.
Okay, great.
Anytime,
so let's
you're
just
welcome.
say that I've studied this paper because what I mean by that is I've seen it.
Yeah.
And it's notable that both refractive surgery and Ortho-K and myopia control, these are meaningful things to improve quality of life.
Absolutely.
Right? And you don't have to go too far into the cornea literature to understand the quality of life impact of things like keratoconus too, right? So you're starting to get into these realms of trying to understand what we do as it relates to how much better you can make somebody's life. And it is not just during the treatment phase, it's for years down the road. So if you're doing something when somebody's 8 years old, right? And you're preventing disease, when they're 50, they may not even ever know that, but if we've got data to suggest that reducing myopia can reduce your risk of retinal detachment and all these other things related to, pathologic myopia, that's really meaningful stuff.
Yeah.
Right?
Yeah,
How could it not impact the quality of life positively?
Right. One of the things that's been kind of interesting in my career, but it seems as we progress even more, is the number of patients who are coming into myopia management practice that end up having a high risk of keratoconus. They have either a questionable topography, and it's almost as if because we're doing myopia management, we're catching these kids sooner because we're doing topography on them sooner than maybe they would have had with a diopter and a half of cylinder in, a primary care practice that's not doing topography. So that's kind of an interesting thing. But what I'm curious if you can talk about for those of us who are doing myopia management, and some of us know these things, but I'm curious for your take. How can I better screen this progressive myope who may be a keratoconus to be able to detect them? And then when should I be sending them to you for cross-linking or for something else? Yeah,
that's a really great question. And it's at the heart of one of my talks today, realistically, because, when you are here, I'm going to preface this answer by saying it's complicated.
Yes, it is.
Because if you're in a myopia management clinic and you're managing people with Ortho-K, we know a few things. Number one, we know we're intentionally reshaping the cornea. We're impacting topography. If we're not, then what are you doing, right? And one of the ways in which that you're impacting topography is epithelial remodeling, right? And what we're learning on the keratoconus side is obviously there's epithelial remodeling that happens fairly early, and it can mimic that of what you do with myopia control and orthokeratology, right? So if you're thinning the epithelium over the cone in an attempt to redistribute epithelial cell thickness to the periphery, and hence change the refractive error, that's the same thing that can appear in early keratoconus. Realistically, topography can look different, right? So you might not see that progressive cone, even though the cornea underneath that contact lens is weakening. You might not see that on anterior surface topography, right? And epithelial thickness mapping. These are two things that I rely on heavily to diagnose and initiate treatment for keratoconus. But what can you do? Number one, you can look at the posterior surface, right? Mm-hmm. That we do know should not necessarily be impacted by Ortho-K, right? So those of you with tomographers and the ability to look at a best fit sphere and any posterior surface elevation, we still know that to be one of the earlier signs of keratoconus. And I think that's key to get on anybody that you're concerned is progressing, over the level of what could be expected for that given age, right?
Yeah.
And it may not be your corneal shape change on the anterior surface, but you may be seeing a progression in myopia. Obviously, is something else that we use commonly. And then, one of the things that we worry about in younger individuals is corneal scarring, right? We know that these younger folks can progress more rapidly, right?
Yeah.
Steeper corneas, younger individuals progress more rapidly when it comes to keratoconus. And so identifying those at risk is critical. And the last thing I'll say is, we also understand that there is a mechanical role to a lot of keratoconus, right? There are some in my field that also have even gone so far as to postulate that there is no cone without rub, right? If you don't rub your eyes, you can't get a cone. And I think that's controversial, but I think realistically, all myopia control patients, I believe, should be screened for eye rubbing behaviors because that is one thing that we know can alter topography, even if it doesn't mean keratoconus, and to signal somebody who's significantly at risk of this. So.
Yeah, I think the tomography statement is really key. And, in optometry, we're starting to get more into tomography. We're well behind you, but you're doing surgery on the cornea, so it's understandable. But with devices like the Pentacam, and we can look at that posterior, it's a really good direction as you grow and grow and grow in your myopia practice. Hopefully, you're also growing in your specialty contact lens fitting and so forth. So a good instrument for people to bring in. And I would say that if you're seeing and treating a patient who is continually still progressing in their myopia, and you start noticing that their orthokeratology lens is not fitting year in and year out, and it's changing. It could be refractive cylinder. It could be that there is corneal cylinder really there, but it would probably be worth a washout every 2 years on those types of children, because it may be that they're not progressing because of myopia, but because of keratoconus, and then get a good new baseline topography compared to that prior baseline topography and see if you've got some questionable changes that could be due to keratoconus.
Yeah, I think I like, and this is my early foray into ortho K, and I like that you use the term washout. And I don't have any primary experience with this, but from my reading, it seems like a few days to weeks is probably enough. Is that usually what you guys are doing to wash out the effects of a lens?
If somebody's been wearing a lens for a year or 2 years, it could take a week or two to get out of it. But unfortunately, I have some patients who it can be up to a month. And, a few years ago here at Vision by Design, I think I saw a poster of identical twins who were washed out, and one took way longer than the other, which makes no sense at all. But it can be that it could take a really long time, or it could just be short. So I usually see them back in a week, and I do another topography. That's not usually an appointment with me. And then we're just evaluating them about every week. And meanwhile, we can be fitting them with a soft contact lens to trace their refraction as it goes down. So the next thing I was hoping you could talk a little bit about is the arena of refractive corrections today. I'll be honest with you, sometimes I stick my head in the sand when it comes to refractive surgeries because most of my continuing education is in myopia management or keratoconus management. But can you walk us through the incredible innovations that have happened in refractive correction? I always tell my patients, if we're going to have refractive surgery when your kiddo gets older, the lower the prescription that you have, the easier it's going to be, the better the outcome. And although I still believe that is true, tell us a little bit about some of the more advanced options that we have. My local surgeon is just crushing it with some of my patients. My one of the past patients I saw, being a -12, she's as happy as a clam. And that's obviously not with a refractive LASIK surgery.
Yeah, I think in writing the talk I'm giving today, I was thinking about how to talk about refractive surgery to a group of myopia management experts, and really where we are in the field right now is we've kind of gone from the earlier days of saying, okay, we can do this, we can reshape a cornea, we can eliminate refractive error. Here are the side effects, and here are the conditions we need to screen for, right? And it was all so objective based, right? It was just hard data, right? Percent tissue altered, residual stromal bed, optical zone size, the effect of the central flattening on the aberration profile of the cornea. We've really moved into now having so many different tools to treat eyes in so many different ways that we're almost tailoring it not as much objectively as subjectively, right? And you can even see that in the amount of refractive surgery studies that get published with patient-reported outcomes right now is increasing, right? And one of the most notable was the Prowell study, right? And how much do these patient-reported symptoms actually show up in LASIK patients? And I think that's made us better, right? It's made us be able to sit down with a patient who might be a candidate for LASIK. Or PRK, right? And some people I talk to say, wait, you guys still do PRK? Yes, we still do PRK. It's a beautiful, beautiful procedure. Or are they a better candidate for an implantable contact lens, right? Which I suspect maybe one of your patients that you're referring to had as a -12.
That's exactly what you meant.
And so, when we sit down with these, mostly myopic patients now, they have these options. Should we do a corneal refractive surgery? And I think of those patients as the low to moderate myopes, even up into the, -7, -8 range is still reasonable with enough corneal tissue. But now all of a sudden we've got these implantable contact lenses that are creeping into the lower, diopter range of myopia and myopic astigmatism, with the toric ICL now available as of, I want to say 2021 or 2020, sometime in that range. We started implanting the astigmatism correcting toric ICLs, which was revolutionary for high SIL, eyes that we get a little bit anxious about when we're talking about these bigger corrections,
right?
And on the corneal surface.
So we have ICL, we have Smile, we have PRK and LASIK, and that's what we have. So I understand LASIK, we're doing a flap, and PRK, we don't do a flap. And these newer procedures, and I have a pretty good understanding of them, but I'd love for you to walk through them for people who may not have been digging deep into them. So tell us what Smile is.
Yeah, so Smile is basically, if you think about LASIK as a two-laser procedure, it's a femtosecond laser to create a flap, and it's an excimer laser to photoablate the stroma underneath and putting the flap back down. Smile is an all femtosecond lenticule extraction procedure. So essentially what you're doing is similar to LASIK. You're docking an eye and you're aiming, a femtosecond laser at a very specific layer of the cornea. And unlike LASIK, where you're only taking one pass with the femtosecond tissue separation, you are in Smile doing a posterior pass as well as an anterior pass in a very specific thickness profile. Then you go in and gently connect all of your bubbles from the femtosecond laser and kind of lyse all those microscopic tissue adhesions, and you free up this lenticule or disc of corneal tissue that you then withdraw from this now pocket of potential space in the cornea that then collapses down on itself, and you've changed the shape of the cornea while operating through a small incision where the SM comes from in Smile. And it really is a beautiful procedure. And what we've learned from that, the advent of Smile is really that, we were hoping it would be kind of the bridge to help some of the dry eye symptoms of LASIK. And I think it has shown to be better at dry eye management or reduction in creation of dry eye problems than LASIK. But what we haven't gotten to yet is the ability to outperform LASIK in visual outcomes.
Okay.
In part because we don't have a way to treat on the visual axis or center the treatment like we do with LASIK right now. So I still think, all things told, I think LASIK still is the standard for visual correction of corneal refractive surgery, at least, and SMILE, I think, has a lot of potential to get there too with advances that I know are coming.
Yeah. So then this implantable contact lens, the ICL, which has been a game changer in so many of our patients' lives, where does this lens go? How do you do this surgery? Tell us a little bit about ICL.
It's we call it a slightly more invasive procedure because generally speaking, we're doing it in a sterile operating room environment rather than a LASIK suite. And we're going into the eye rather than operating on the surface of the eye. We make an incision approximately the size of a cataract wound. And we insert the folded up Collamer lens into the anterior chamber with a little bit of viscoelastic support to create space. And then once it's in the anterior chamber, we ensure the right orientation and we gently tuck the foot plates underneath the iris tissue and then bring the pupil down, right? So you need a good dilated pupil to be able to get it back there, right? You're going to the what is technically the posterior chamber of the eye. And the foot plates are resting on or near the ciliary body and zonular complex. And it vaults up over the crystalline lens, and it does a remarkable job of correcting a wide range of myopia and myopic astigmatism.
So basically, you're just putting a piggyback onto the existing crystalline lens. You're just resting it right on there. How many foot plates are there?
There are, in the available implantable contact, and I should preface this, my mentor Vance still puts in the Verisize Iris Claw, also technically an ICL. So I'm speaking specifically of the Evo lens right now from Star. There are 4 foot plates, and they there is a specific orientation that these lenses need to be put in because they have a vault, right? And that's one of the main things that we're measuring when we're looking at these patients after surgery, and it can impact their refractive error. Also, what we're learning is in slightly older patients, it can affect accommodation, right? So if you don't have the proper vault, and particularly if your vault is a little low, you can lose accommodation.
Yeah.
And so sizing, if centration is the main goal for a SMILE, I'll say higher order aberration treatment is the main goal for LASIK. For ICL right now, it's sizing, right?
Yeah.
And that's all on the doctor to order the right lens, size it right. There are so many different tools that we use, which tells you we don't have the perfect tool yet to try to figure out exactly what size lens to put in these eyes. But the calculators we have are really good right now. And an exchange isn't the end of the world, right? Yeah. So the beauty of the ICL is, as you can imagine, you're not permanently changing any tissue.
Yeah.
Right? You're making a small incision, you're tucking a lens in, but it's a fully reversible refractive surgery. And man, is that attractive.
Yeah.
Right?
Yeah.
I mean, it is so attractive for certain patients, particularly high myopes. And I absolutely love doing it.
And it's so good for the dry eye aspect of what we've dealt with in 100%. The past with LASIK and, being able to treat. And what would be the lowest refractive correction that you may choose ICL over LASIK? Well, is that all corneal thickness decision?
Great question. There's so much at play when we're talking about refractive surgery evals. Somebody with an irregular cornea that we don't necessarily want to treat, but maybe has, and to answer the simple question is it's a -3 because that's as low as the power will come.
Yeah.
But there is there's nobody in that range of available ICL that I wouldn't consider it. As long as they're a good candidate and there's a really good reason, and that's going back to that original comment I made about, hey, a lot of this stuff is now subjective, right, rather than objective. Okay, so how the quality of vision that you can get from an ICL, I think, is oftentimes considered superior to that of a refractive corneal procedure, right?
Yeah.
And so we're thinking about these things and lower myopes now, as a way to not have to permanently change corneal tissue too.
Yeah. Yeah. Well, typically we go for 20 minutes and we're already at 25, and I have so much more to talk with you about. This has just been extremely entertaining and so helpful. I appreciate you sharing all these perspectives with us.
Yeah, to be honest with you, I forgot we were talking on a podcast, and that was kind of fun. So
that's what I love. Yeah.
Thanks for having me on.
Absolutely. Thank you for joining us for this episode. Make sure to like and subscribe. If you could go to your podcast platform and give us a 5-star review, that would be so helpful. Thanks and have a great day.
1, 2, 3, 4. Thank you for tuning in to the Myopia Podcast. If you enjoy our content, please leave a 5-star review and don't forget to subscribe for more great episodes.